Thank you very much for joining us. I'm Yousif Ahmad, an interventional cardiologist in San Francisco at UCSF and an associate editor at JACC. I'm joined today by Shamir Mehta. It's really a privilege and honor to have him join us. He really needs no introduction as one of the foremost clinical trialists in the world for interventional cardiology from the Population Health Research Institute in Hamilton and McMaster University. He's going to talk to us about his TCT late breaker, which is going to be a simultaneous publication with JACC. It's the STRIVE trial, to give the full title, Intracoronary Low-Dose Recombinant Tissue Plasminogen Activator in Primary PCI for ST segment elevation myocardial infarction and large thrombus burden, a randomized trial. So Shamir, please just tell us a little bit, if you don't mind, about the rationale behind the trial, why you guys conducted it, why this was sort of the next question you wanted to answer. And then we can dive into a little bit of detail about the trial.
Sure. Thanks. Thanks for having me. It's a pleasure. So we became interested in this trial after an early study with streptokinase had demonstrated benefit on microvascular obstruction, various parameters of microvascular obstruction, and the with the advent of multiple studies that have been shown to that tried to improve microvascular obstruction and essentially failed, this problem has persisted, and microvascular obstruction is the single largest unresolved problem in patients undergoing primary PCI. Mechanical thrombectomy was tried; it didn't work. Intravenous GP2B3 inhibitors were tried, and the results were variable. Facilitated PCI was evaluated more than a decade ago, where full dose lytic was given before coming to the cath lab, full or half dose lytic given intravenously, and those trials also failed. Intracoronary administration of a lytic is a really interesting concept because you target it. So microvascular obstruction in STEMI is due to distal embolization of thrombus. That's what initiates it. And thrombolytics dissolve thrombus. That's what they do. That's how they work. And so if you can deliver it exactly to where you need it in the microcirculation, then presumably there would be a benefit, rather than giving it systemically through a vein where you have a first pass effect in the liver and it's distributed throughout the entire body, and it's in a relatively diluted form when it tries to target the microcirculation. We're giving it directly through a microcatheter. The advantages are that you are sure to get it where you want it to be, and secondly, you can use a markedly reduced dose. So 100 milligrams of TPA is what we normally give. You can use 10 or 20% of that dose targeted in the microcirculation, and you're still getting about a 10 to 20-fold higher concentration in the coronary microcirculation than you would by giving it systemically. So you're focusing it and targeting it. And so we wanted to know, would that work? We had a lot of hope for that.
It almost sounds like a slightly familiar story, a definite clinical problem that we have with thrombus in STEMI, and biologically plausible and actually quite elegant solution, and then some early trials showing benefits in surrogate endpoints. It is reminding me quite a lot of the thrombus aspiration story in terms of how this has panned out. Any thoughts on that before we kind of really dive into the methodology and results of STRIVE?
Well, I agree. I mean, these are concepts that we choose to spend a long time studying. We work hard doing it because biologically it seems to make a lot of sense. I mean, why wouldn't it work? Lytics work when you when you have an infarct and you don't have primary PCI. We know that they're proven therapies. We're just refining how we deliver those therapies, and it seems like almost a no-brainer, but we need clinical trials to prove it.
So tell us how you guys set up the trial. What was the design? Who were the patients that you enrolled? Was it an attempt to kind of enrich the population?
Yeah, we wanted to show that it improves microvascular obstruction. That is the essential issue prior to a large-scale outcomes trial. If it doesn't do the very basics of what it's supposed to do, then it's unlikely to lower events. It's like a blood pressure drug. If it doesn't lower blood pressure, it's unlikely to reduce cardiovascular events. The same thing here. If this therapy doesn't improve microvascular obstruction, then it's very unlikely to improve clinical events. And so we designed a trial to look specifically at that. It was a randomized double-blind placebo-controlled trial. Patients were recruited if they had large STEMI. So small STEMIs were not included in this trial. We wanted large STEMIs, large anteriors or large inferiors with at least 8 millimeters total ST segment deviation. And they had to have a large clot. So we wanted to show that this worked. We had to enroll patients with a large thrombus, and 95% had thrombus grade 4 or 5. And then they were randomized into 3 groups, 2 doses of intracoronary TPA, 10 milligrams and 20 milligrams. And then there was a matching placebo, which was saline.
And then tell us then about the results, the primary outcome and all of the other things you learned from the trial.
Yeah, so we gave the drug. So we established antegrade perfusion with either balloon angioplasty or thrombectomy. And then microcatheter was put down into the coronary artery, and then the drug was injected over about 3 minutes. We looked at a composite outcome, looking at myocardial blush grade, ST segment resolution at 30 minutes, distal embolization, and major adverse cardiovascular events. So it was a composite outcome. We wanted to use at least 2 measures of microvascular obstruction because we didn't want to miss something, so we used an angiographic method with myocardial blush grade, which has been well validated over the years. And we also used ST segment resolution. So we used an electrical. We were able to look at ECGs, which was evaluated separately in a different ECG core lab. Just to be absolutely certain we didn't miss something potentially that could have been there. And the results were surprising to us. We didn't find a benefit of intracoronary TPA. In fact, the results were completely neutral. The relative risk was 1.00, and we did not find a dose response between the 10 and 20 milligrams that we gave.
And so really, I think as you said, if we aren't improving those perfusion metrics, the TIMI flow grade or the ST segment resolution, then it really doesn't stand to reason that there's going to be an improvement in clinical outcomes, because we've already seen this pattern previously, as we had discussed, that even in cases when these surrogate endpoints or these markers of perfusion are improved, that doesn't always relate to clinical benefit. So do you think that there is now a role for a large outcomes-based trial similar to the thrombus aspiration ones?
I'm never against doing trials. I think you need a plausible mechanism of action, and if the mechanism of action is not what you thought it was, does it really make sense to expand it into a large outcomes trial? Is that really where you want to spend your time and energy? This is not the first trial. This is now the 3rd trial to show neutral results. There was a few smaller studies, the ICE-T trial that was done by Mike Gibson. There was a good, larger trial using MRI as an outcome, a multi-center trial from the UK that also did not show a benefit. So STRIVE now is the 3rd trial showing a neutral result for this question. So I'm not sure that a large outcome trial would be indicated at this point, given that there is one more trial that is ongoing that is being done in Australia. We'll see what the results of that trial show.
And then any safety concerns with this approach? That I did see that there were some VF episodes. Can you speak to that a little bit?
Yeah, well, first, our primary safety outcome was bleeding, and we didn't see bleeding. And there was no major bleeding. There was only one clinically relevant non-major bleed. But yes, during study drug injection, there were more episodes of VF that we saw in the intracoronary TPA group compared with the placebo group. And it didn't quite reach significance. The p-value was 0.06, but for all intents and purposes, there were definitely more episodes. And the mechanism of that is interesting. It may have had to do with more rigorous of an injection of the study drug. And it was double-blind trials, so investigators didn't know if they were giving active drug or placebo. So, this applies to the placebo arm as well. But when you're rapidly injecting, an active drug, there are differences with placebo. So the viscosity of reconstituted TPA is different than placebo, which was saline. The pH is different. The solvent is different. So TPA is reconstituted in sterile water. So essentially, you're injecting sterile water into the myocardium versus saline. Did that have an effect? We don't know the answer, but we did observe this, and it's real. It was not individual investigator. Was seen across different investigators and across different sites in the trial. So it's a real phenomenon.
So if we look at the trial, in totality, and then put it in context with the existing evidence base, I mean, it seems that we can, more or less conclude now that, this strategy of intracoronary lytics doesn't appear to be beneficial. There may be a safety signal seen in this trial with ventricular fibrillation with unclear mechanism, but appears to be a very real phenomenon, as you just described. And so, for our readers, I think we can conclude that this doesn't seem to be, a strategy that we're going to take forward either in clinical practice or in larger scale outcome trials. What do you think is the next kind of frontier or other potential therapeutic targets to resolve this problem that, as you elegantly described at the beginning, is the number one issue still facing us in patients with ST segment elevation MIs?
People have been at this for so long now that in so many attempts to improve microvascular obstruction have failed. And I'm wondering at this point, that we need to go back to the drawing board and try to understand what the fundamental problem is with microvascular obstruction. I think we need more research into that. Is it as simple as obstruction, of the microvasculature with thrombus? That's what we have been thinking, but it may be more complicated than that. It probably is. It almost certainly is. Myocardial hemorrhage it plays an important role. That is being elucidated more and more. There is myocardial edema. And it may not be so much that we're looking at microvascular obstruction as much as we're looking at microvascular obliteration. And that, no matter what we do, we may not be able to improve it unless we start thinking outside the box and start to understand really, what we are actually treating.
And then I guess I'll switch gears slightly and ask you to kind of take off your clinical trialist hat for a moment and put on your interventional cardiologist, practicing hat. What is your strategy for dealing with this problem in the cath lab when you have a patient with a large MI and a heavy thrombus burden? How do you personally approach these cases?
We usually, if it's a very large thrombus burden, we will aspirate. Now, the routine aspiration thrombectomy is not effective. Targeted aspiration thrombectomy with some of the newer devices that we have may be effective. So, if it's a very large thrombus burden, then we will do that. We will use, the high intensity P2Y12 inhibitors. We will use high dose heparin. We do use a 2B3 inhibitor. We will give eptifibatide in that case. If we can direct stent, then we will, but it's a double-edged sword to direct stent in STEMI. You may avoid doing additional predilatation and causing embolization, but post-dilatation is a major problem in STEMI as well. You get a lot of embolization. You post-dilate the stent. You release a lot of clot when you post-dilate the stent. So sometimes in STEMI, it's better to size the artery 1-to-1, to actually size it properly, open it, establish antegrade perfusion, and size it properly so you can avoid post-dilating the stent. So those are kind of, that's our approach to doing that, to treating a large thrombus burden.
Yeah, our approach honestly is similar. And then again, for our readers, the use of intravascular imaging to size your stent, as you said, and then to determine if there's a calcium burden or not. If there's no calcium burden, then I think this concept of direct stenting with a 1-to-1 size stent to high atmospheres of pressure and avoiding post-dilatation is a very good one. Obviously, in patients with severe calcification and a thrombotic occlusion, that's not possible and is more challenging. We also use distal vasodilators without evidence to support it, but to try and kind of allow the microcirculation to better tolerate any embolization that we give distally. As you talked and you said, use of thrombus aspiration with the newer devices, we also do that in heavy thrombus burden cases. Is there any role you think in repeating a thrombus aspiration trial with a different device, and then maybe trying to enrich the population in the way that you did in STRIVE by selecting out these heavy thrombus burden cases rather than, all comers with MI?
Yeah, I think that the technology has improved. And so, I think it is something worth looking at. And I believe there are trials ongoing right now with the new devices in thrombus aspiration. So probably is indicated. And, your approach to treating this is very, very similar to what we do. And but it continues to be a problem.
So I want to thank you, for joining us today. I want to thank you for the discussion and talking about the trial, and also, for publishing this trial in JACC. We are so looking forward to your late breaker at TCT and the simultaneous publication. And thank you again for your time.
Great. Thank you, Yousif. My pleasure.